Morning. Good morning. I guess we are. Bagasha's public PhD defense. It's titled Quality of Life Among Patients with Kidney Failure, a Mixed Methods Prospective Analysis, Exploring Dynamics, a 12-month survival, and associated factors. Dr. Bagasha has a MBCHP and a master's in internal medicine, and she was supervised by Professor Eric Katabira, who is here with us, Professor Dr. Mael Petrova, and Dr. Moira Leng, and she's going to take us through her study, her experience, and we learn a little bit about the quality of life in patients with kidney failure. So we'll have a presentation by the candidate, and that should take about 30 to 40 minutes. Then after that, we'll have an intellectual discourse with the opponent, who will introduce later on. After that, we will have discussion or a couple of questions from the internal examiners as well as the external examiners. That should take about 20 minutes. Then we'll have the audience ask one or two questions. After that, we'll have a breakout session where we'll go to determine the verdict, whether you have passed or failed. Then we'll come back. That should take about 5 to 10 minutes. Then we'll come back to announce the verdict. Then after that, you give us a few remarks before we call off the examination process. So the examination panel is made up of internal and external examiners. Then we have an opponent. The internal examiners are Associate Professor Bruce Chirenga, Associate Professor Irene Andia Pinaro. Then we have Professor Julia Downey as the external examiner, and she's online. Then we have the opponent, Professor Edwina Ann Brown, who will have a little bit more time, I think. So with that, I know we have people who are online. We have about 40 participants, and those who are present physically, you are welcome, and we are ready to go. So over to you, please, for the next 30 to 40 minutes.
Thank you so much, Professor Kadu. I'd like to start by thanking all of you who have been able to make it to come and attend my PhD defense. So my name, as I've been introduced, is Bagasha, but what they didn't say in the introduction is that I am a nephrologist working in Mulago National Referral Hospital. And as a nephrologist, we always try to take up every opportunity to advocate for kidney health. So I hope this would be a good opportunity for that. I'd like to start off this by telling you a story. We like to advocate using stories. So this story is about Godfrey, and patients like this is the reason why I ended up doing this study. So Godfrey was a 23-year-old male, so for the first time in the outpatient's clinic. And the first time he came because he had body swelling, but also he had a blood pressure of 230 over 130, which is really, really high. And when we did his labs, we found that his creatinine was very, very high. So patients like this always come for the very first time with end-stage kidney disease. And because of that, they come when they have a huge symptom burden, and they always have a lot of concerns and a lot of worries about their health. So when a patient has this level of kidney failure, only equivalent to 4% in layman terms of kidney function, it means that you only have 3 options of care available to you anywhere you go in the world. So the first option of care, which I explained to Godfrey, is that he could get a kidney transplant. Kidney transplant gives you the best option in terms of quality and quantity, because it gives you a new kidney and therefore replaces all your kidney function. The downside is that it's expensive. In Uganda, you won't be able to do it in the country very easily, and you, after surgery, would need to continue with supportive medication. The second option is to do hemodialysis, which hemodialysis gives you, according to studies that have been done, some quantity of life and some quality. But it also comes with a downside in that it's costly. It's 300,000 per month. And for a person like Godfrey, who was a student, 23-year-old student, actually, at that time he was doing his social works bachelor's degree at Makerere, 300,000 per month is not very easy money to come by. And then the third and final option is to have conservative management, which is what's in our study we call the non-dialysis care, which is supposed to improve your quality of life, and that's the goal, but may not give you quantity, and the costs would be your routine care costs. So after having this discussion with Godfrey, we then had to come up to a decision. What should we do? Which option should we take? He opted to go for the dialysis option. And once he decided this, the question that he asked, and this is the question that every patient will ask, is what do I get in return for paying this amount of money, in return for this kind of investment? What do I get? And what you get is the quality of life. You're supposed to get good quality of life when you come to your doctor asking to have your problem sorted, your treatments, when you opt for treatment. So quality of life then becomes the return on investment that any patient would expect to get, and therefore it's an important marker to see if the doctor has done a good job or not. So our outline is I'm going to give you a brief background about kidney failure. We'll talk through the methods, the results, and I will highlight this as we go along. So to begin with, kidney failure is very abundant. We have estimates of over 850 million people suffering from kidney disease. This is twice the number of people who have diabetes, almost 20 times the number of people who have cancer. So it's very prevalent. This is why each and everyone knows at least 1 or 2 people who have kidney disease. In Uganda, most of the studies that have been done have showed that there's 1 in 5 chance of coming across someone who has kidney disease. So kidney disease is very prevalent, and the international bodies have equally recognized this because just last month they passed a resolution demanding that it should be prioritized by every nation. Now, kidney disease can be easily broken down into 5 stages. So you define it, first of all, by saying that your kidney function is abnormal for more than 3 months as chronic kidney disease. And to say that it's abnormal, we look at your urine outputs look at your urine, see if there's protein in your urine, and we stage that depending on how much protein you have. And then we do a blood test to look at to calculate your estimated glomerular filtration rate. So if it is above 90, you're stage 1, and that is good, and that's the green zone. But if it's below 15, that's bad, that's the red zone, and this is where our Godfrey showed up in. And this is what our study was going to focus on, patients who have kidney failure. So just to highlight, the option that we chose was dialysis. What does dialysis do? So dialysis is the type of therapy that helps to clean blood in simple terms. So it uses a filter, that's the dialyzer. Blood comes from the person, goes through the filter, gets cleaned, and goes back to the person, and the waste products are taken off as waste products, so they don't disturb you anymore. So dialysis will remove toxins like urea, poisons, phosphate. It will correct electrolytes, and it will correct acid-base imbalance, but it does not produce hormones. So therefore, at a bare minimum, it does not equal to kidney function, and this is why transplant is the best option of care for our patients. But in the absence of that, we will go with dialysis. So there's challenges looking after patients who have kidney failure in Uganda. The first is that looking at our population, we only have 15 specialists. And right now we have 2 in the room, meaning that there's only 13 specialists looking after Ugandans right now. The nursing ratio is 1:10 in a busy dialysis unit. So it means that the nurse does not have time to offer the other services except connect and disconnect the patients. We have very minimal support services. In Mulago, for example, there's 1 social worker providing care for the entire hospital, and maybe 1 dietitian providing care for the entire hospital. Transplant services are not there, meaning that when a patient goes onto dialysis, there's no exit plan. And then there's few dialysis services. So this map of Uganda shows you those 2 red dots. Those are the only places within Uganda where you can get dialysis care. So that means that if someone stays in Karamoja, for example, that's at the extreme end, they have to rent a house in Kampala to be able to do dialysis. So that means that the indirect costs will be significant on top of the dialysis costs. Those 2 stars are the new places which are now able to provide dialysis, but they only have about 4 to 5 machines each. So that means it's still not enough to cover the population. So let's talk about quality of life. Quality of life is the perception that an individual has about their life, and it bears in mind the context of the patient, what their social services are, what their goals are, what their expectations are, what their concerns are. And this is why it's a multidimensional concept. It looks at the physical health, psychological health, economics, religion, social health. So it's not just how the patient is feeling physically, but everything else that contributes to that. An easy way to describe it is to use the Kalman's gap. So the Kalman gap tells you that the bigger the gap, the worse the quality of life. And the gap is between the patient's hopes and expectations or aspirations. So in this case, Godfrey is a young boy, 23-year-old, wants to go to school. His quality of life is he wants to be in school. But the reality is that he cannot attend school if he has to attend dialysis 3 times a week, and he's not feeling very well. So if, as a doctor, you're able to modify his expectations and improve his circumstances, then you'll have improved his quality of life. So we set out research questions. So the first question is, what is the quality of life the patients who have kidney failure is affected? The second was, how does quality of life score compare for patients who do dialysis and for those who do not do dialysis? And the third one was, what is the survival for these patients over a 12-month period? Our problem statement is that kidney disease is very abundant and prevalent in our setting. So we anticipate that by 2040 to be the fifth leading cause of death. And then global standards of care mandate that kidney disease treatment should focus on reducing progression and improving quality of life. So it's not either or, it's both. And there's little that we know about quality of life for patients in our setting. And then the justification was that we'll be able to generate evidence. So you're able to tell Godfrey that if you do this, this is how your quality of life is going to be. We'll be able to make informed decisions using this evidence, and we'll be able to formulate policies which are specific for our patients. So it was a mixed method study. Our objective, number one, was to measure the quality of life. Number two was to compare between the two management groups. Number three was to calculate the mortality over 12 months period and see how quality of life changes. And then, because we had to look for a tool, we added a fourth methodological objective in which we looked for the tool, translated it, and made sure that it actually works in our setting. So we validated it and culturally adapted it. And then, because of the mixed method study, we explored the lived experiences of patients along 5 domains of quality of life. So the physical health, psychological, spiritual, and eventually the daily life of the patient. So our hypothesis was that by virtue of the fact that we are living in a resource-limited setting, patients with kidney failure are more likely to have a low or reduced quality of life compared to patients in patients in more affluent settings, and also patients managed with non-hemodialysis care are more likely to have a better quality of life compared to those who are receiving dialysis. Our conceptual framework was that kidney disease causes physiological and biological abnormalities. These abnormalities present as a high symptom burden for the patients, and because of the high symptom burden, your physical and mental functioning will be reduced. This will result into a low quality of life and increased morbidity and mortality for the patient. And many things will factor into play and result in how the patients present. So for example, if the patient is old, they are more likely to have multiple comorbidities, and because of that, they'll have a high symptom burden. If the patient does not have good healthcare insurance, for example, they won't be able to pay for the services, and therefore they'll have a high symptom burden. So we tried to focus on the things which are in the dotted line, so the individual patient characteristics and patient environment, as well as looking at how they interplay with quality of life and survival. So let's go to the methods. The first thing we had to do was to find out, how do we measure quality of life? We opted to use the Kidney Disease Quality of Life short form version 13 because it has been used in multiple countries and validated in those countries, but it has not been validated in Uganda in our setting. So we did that, we culturally adapted it and validated it to make sure that it actually gives us true and accurate findings. And in fact, because this work is published, it's available for anybody to use. And we'd like to hear information from anybody who uses it because it's an ongoing improvement. So if you give us information, we make it better and therefore we measure more accurately. So the Kidney Disease Quality of Life version 13 has 3 major domains. It's a combination of an older form, which used to measure quality of life, for the short form 36, and they added on a kidney disease component. So the short form 36 originally used to measure mental and physical health components, and under those components, under the principal domain, there are subdomain questions, and the items that you, the items under each subdomain question is the number of questions that they ask for that particular subdomain question. So it then combined the short form 36 together with the kidney disease specific components to add things which are specific for kidney disease. So it was a mixed methods prospective analytical study carried out at Kirudu. So we collected the quantitative data alone, qualitative data alone, and then combined the two to be able to have a better understanding of the scores that we get. We enrolled patients who are aged 18 years and above, they had to have documented evidence of kidney failure. So that was eGFR less than 15, and they had to give the consent. And then we removed them because we had to follow them up if they had no access to a mobile phone. And for the qualitative bit, we used purposeful maximum variation sampling to get patients from the bigger cohort who were then would then be part of the qualitative cohort. To estimate our sample size, we calculated that we'll need 218 patients, but because we know that patients drop out a lot because of a high mortality, we adjusted for attrition at 30%, and then also considered the fact that the non-dialysis group may not live longer. So we had more non-dialysis compared to dialysis patients. And for the qualitative bit, we estimated that we'd get to saturation once we get to 30 interviews, based on a study by Namuka et al. Looking at quality of life of patients who had heart failure. So how did we apply our tools? We applied our tools by asking patients the questions every 3 months. At baseline, we recruited and got informed consent, and then every 3 months applied the kidney disease quality of life reform. And then the interviews, we only did them every 6 months. We analyzed our data for each of the different objectives to be able to get the results that we wanted. We used in vivo version 12 mathematic analysis for the qualitative analysis, and the different analytic tools for the quantitative objectives. So what results did we get? To begin with, for the methodological objective, we had a total of 382 participants. The reason why these were a little bit more is because we had 4 participants for the translation, and this included 1 academic language, Uganda language speaker, and 4 native Uganda language speakers. We had focus group discussions to look at the tool and see if it actually makes sense. And this focus group discussion was for health workers working with patients with kidney failure. And then we had cognitive interviews, 5 participants. This was potential patients looking at the tool and seeing if the questions make sense. And then we did a descriptive and correlative analysis on the 364 participants. And those 364 participants also participated in the other 3 objectives. So to get to our 364 participants, we screened 1,594 participants. Most of them were inpatients, and the majority were not eligible because they were stage 1 to 4 of chronic kidney disease. When we finally got to our patients with kidney failure, 26 were not eligible because they were too sick. And eventually, when we got to our 364 participants, we divided them 2/3 and a third, 2/3, 240 on the non-dialysis group, and a third on the hemodialysis group. So what did we find? In terms of patient characteristics, the first thing is that we had more males than females. This is probably because it's a tertiary center, and males probably have more capacity to access a tertiary center. The second thing is that our age range our age is of really young patients. So our median age was only 46, so very young patients. And the third thing, which was really interesting, was that most of the patients who were on dialysis were more likely to be educated than the patients who are receiving non-dialysis care. And then finally, looking at the sources of income for patients, although 92% say that they were employed, only 45 were getting their main source of income was from their job. So it means that even though they say they were employed, most of them were not able to get funds from their jobs. Then, what did the scores show? So to begin with, there was a statistically significant difference in terms of the kidney disease composite score. The patients who were on dialysis scored better in this group, but in the overall health score, 94% of the patients had a low quality of life. So this means that patients generally, whether they are on dialysis or not on dialysis, have a low quality of life, and it was significantly, well, it was really lower than 50. So in terms of the comparison of the 2 groups, so you see that generally patients had a low quality of life, but in the areas where there was a statistical a significant difference between the two groups. The patients who are not on dialysis scored higher than the patients who are on dialysis. So the patients who are not on dialysis have a slightly higher advantage in terms of quality of life compared to the patients who are on dialysis in that regard. So we looked at factors associated with quality of life, and the only things which were significant were things to do with finances. So if your main source of income was your job, you are likely to have a low quality of life compared to if it was not. And in terms of breadwinner, if you are the breadwinner or on dialysis, you're likely to have a lower quality of life compared to those who are not. But this was only in the kidney disease specific and the physical health specific domains. In the mental health specific domain, this was not the case. And then looking at survival, our median survival was only 8 months. So overall, patients survived for only 8 months, which is quite low. And at 12 months, we only had 26% of the patients who we started with. So the dropout rate is quite significant. And there was no difference between patients who are on dialysis and patients who are not on dialysis, or patients who are male or female. And looking to see what factors associated with mortality. So one of the things is if you are male, you're likely to have a higher mortality than if you're female. If you're employed, you're likely to have a better quality of life than if you're not employed. And if you're depending on your personal savings, you're likely to have a higher mortality than if you're depending on donations. And then in the multivariate analysis, the finances dropped off, and the only thing we had left was if you are male compared to if you're female, and your religion. So if you're Protestant compared to if you're Catholic, you have a better quality of life. And this was only in the non-hemodialysis group. In the hemodialysis group, there was really nothing significant there. So looking at the dynamics, how does quality of life change over time? We had many graphs, but if you look at these graphs, overall, there is a slight increase in quality of life over the 12 months period. And the most significant declines we saw were in social supports, in overall health, and in sleep. So in these three areas, quality of life declined significantly for the patients who are able to survive up to the 12 months mark. So looking at the qualitative area, we were able to get 35 interviews, which surpassed our initial estimate of 30. But by the 6 months mark, this had declined to 11 and then 10. And then looking at the responses, psychological health came out as a key area. So mental well-being was significantly affected. This patient was a dialysis father to a dialysis patient, and he said he sold everything, his land, his house. He had nothing left, and the dialysis was still going on. So his worry was, what will he do for the rest of his patients? And then in terms of perception, how the patient looked at themselves. So this was a 44-year-old male on dialysis. And her concern was, so her assessment was, what was really, really worse, where it was worse is having to do it in a bucket and then you watch somebody work it, take it to throw it away. So it was really a big change in her perception of herself compared to how she was like before. And then in physical health, the experience of navigating the healthcare system was a big thing that came up, as well as the symptom burden. And the experience would reflect in our story of Godfrey, for example, who ends up in the hospital when he has an EGFR 4. So he has kidney failure by the time he reports to the hospital. And then in terms of social health, the perceptions of family support, patients felt that they were really supported. Although, as we can see with the quantitative study, with time, the support wanes. But in the beginning, they actually feel like they have a lot of support. Spiritual health came up as faith being a major contributor to sustained hope. And patients talked about all their sources of hope. So, for example, their children, seeing patients who are sicker than they are when they come to hospital for the very first time, and having an opportunity to actually access treatments. And then when it comes to daily life, the finances came up again. So this patient talks about food. So they told me which food to eat and which food not to eat, but because I can't afford Whenever I find the food, when I'm hungry, I will eat even when they stop me from eating it. So finances then became a problem, as well as deficiency of information. So for discussion, we compared our quality of life scores to what has been found in other studies. And as you can see, Uganda is significantly lower than in other countries. And we thought that this is most likely to be true because of all our resource limitations, but also because we had validated our study and really trusted its finding. And then in terms of survival, so Uganda had a 1-year survival of 26%, but if you compare this to the Indonesia Renal Registry, where their age was even higher than ours, they had a 77% survival at 5 years. So they actually are doing well compared to the European studies, which show an 84% 1-year survival, and Brazilian study that showed 82% 1-year survival. Some of the factors that we found which were similar, we found religion and male sex. Male sex has also been found in Indonesia study, but other things that they found were like twice weekly dialysis, which you will find is what we usually do for our patients to be associated with mortality for patients, and then vascular access. I'm highlighting this because this is what our patients get. They get central venous catheters because they cannot afford to have other options for vascular access. So in terms of comparing Uganda to the global standards, so in the global standards, we must have a minimum of 12 hours of dialysis per week, but Ministry of Health pays for only 8 hours, and maybe that's the reason why our patients don't do so well. And then, despite the fact that you get a subsidized fee for those 8 hours, most of the patients will still not attend. So 6-month review of patients in Chirudu showed that less than 50% of patients consistently attended dialysis 2 times a week. And this is probably because of the indirect costs, things to do with transportation, accommodation, and being able to access the dialysis. And then 85% of patients had central venous catheters, and this probably contributed to the higher mortality for our patients. Other guidelines say that you should have shared hemodialysis care and interdialytic exercise, but this is only encouraged in our setting and is not implemented because of the resource limitations. So in conclusion, I think we have answered our questions. The first was, what is quality of life for our patients? Quality of life is low, we have found. The second is, how does it compare? We found that there is no difference between the two groups. And we found that for some subdomains, patients on dialysis actually scored higher than patients on dialysis. And we also found that finances play a big role in quality of life for patients, but not in all domains. And then in terms of survival, what was the survival? So very low survival, only 12%. Overall, we found that the scores generally increased, except for some few domains where the scores declined. And then we found that sex and religion in our setting actually contribute to survival for patients. We also found, when we look at our tool, that it can be used in our setting to measure quality of life, but only in research settings, because we validated it in research settings. So the recommendations to policymakers is that, first of all, quality of life needs to be addressed. It's not being addressed. And it can be addressed in a multitude of ways. For example, integrating it into daily care, early palliative care interventions. And then we also want to recommend that people be screened early so that we don't get to kidney failure. As you saw, most of our patients were actually in the stage 1 to 4. So if we're able to stop those patients from reaching stage 5, that would be good. We need to increase access and affordability, and we need to improve information systems through a variety of ways. And then for healthcare workers, again, the same thing. Think about quality of life. What return on investments are you giving to your patients? Think about that as you address your patients and help them to be able to reduce the gap between their reality and their hopes and aspirations. And then develop tools so that not just you, but everybody else around you is doing that. And we need to have models of team approaches and develop screens which can be used in other places. And then For the healthcare, for the family and the patient, social support declines. So you need to find ways, and patients need to be warned early that your social support, which you see at the front, is going to decline in the long run. This is a long-term care problem. And then spiritual support is helpful, so we need to incorporate that into the care, and decision and shared decision making is really important, so our patients are fully aware. So to end, what happened to Godfrey? Godfrey was a 23-year-old man I talked about, had to stop school because his father told him, you either choose life or you choose school. So he had to choose life, so he stopped school. But Godfrey's story is very unique. And this is the reason why it has to be told. He was able to convince someone to pay for his dialysis. So he was able to receive 3 times of his dialysis and was well enough to actually become the first kidney transplant patient in the country. So he did very, very well. But he is the exception. All the other patients were not able to do as well as he did. So I'd like to end by also acknowledging my supervisors, all of my family and friends who are here. I thank you all for all your support. This would not be possible without you.
Thank you, Liz, for first of all for keeping time. So you can have a breather before we start the examination. And it's my pleasure to introduce Professor Edwina Ann Brown. I think when you just show your face to the people who are available when your time comes. And in case if I've left out anything which is important, you can highlight that. Professor Edwina Ann Brown is a professor of renal medicine. She's a consultant nephrologist at Charing Cross Hospital and has a keen interest in quality of life in kidney disease, as well as a peritoneal dialysis in Africa. She's well published with over 200 papers and has written several books and chapters. Professor Edwina Brown, you are welcome. You have about 40 minutes to interact with the candidates.
Well, thank you. I mean, are you able to unshare so I can actually see you, Peace? There. Hello.
Hello.
Good morning. That was a wonderful talk, and lovely to hear the story of Godfrey. I've got an 18-year-old student at the moment who's doing engineering at Imperial College, who's on peritoneal dialysis, and you know, it is really difficult in all healthcare resources to be young and at school and having kidney failure. It is really difficult. So I'd like to, I enjoyed reading your thesis, and I've made a few comments as I went along. So let me just go through them. The first thing is why do you think kidney disease is more common in Uganda than the global average?
So the global average is about, well, in Africa, it's about 13 to 14%. And the kidney disease studies that we have seen were, so the study by Dr. Sinabulia was in a hospital setting where they found the 26%. And we think that these patients who are coming into the hospital, so they're screening them. And then the second study that I quoted by Dr. Kalesula et al. Was a community study. So they looked at the urine of patients, and sometimes you would find blood and urine, which may not be really a marker of chronic kidney disease. So we don't have specific studies which actually look at the key measures that have been used internationally for kidney disease. But that said, we know that the healthcare services, because of what they are, patients often present late, and hospital studies will always have a higher prevalence compared to non-hospital studies.
Sure. Okay, so just a minor criticism, and I'd like to see a paragraph somewhere, is describing your hemodialysis group in slightly more detail, because what I couldn't find was how long they were actually on dialysis for, how many hours they did, how many sessions, etc. And that's just useful for, certainly for somebody like me from a high-income country, because what always shocks us, and I've heard people talk on this before, you know, the data from India and stuff that Vivek Yar presents, is people stopping dialysis.
Yes.
During the course of their, so I think that would be really helpful. And that just needs to be added as a paragraph, you know, at some point in your thesis.
Okay.
The other thing that I wanted to really pick up on before I sort of just go through is your use of the term conservative care.
Yes.
And that was really discussed in great detail in the KDIGO supportive care and kidney disease controversies conference, and definitions that came out from that, you know, by Sarah Davison, and the concept that your patients or the people in Uganda who don't access dialysis for economic reasons is not what we understand as conservative care in high-income countries. So that was not having dialysis for economic reason. So there's really no choice about having conservative care. And you can't use, and sometimes you did later on in the discussion, use the conservative care literature as a comparison group.
Okay. Yes. So the two options will be the conservative option, non-renal supportive care. So the definition has been evolving over time. So it's said as conservative management, but the way in which we understand it is different. So ours is the choice restricted option.
Yeah.
And in our setting, we actually, when we say, this is why we decided to use non-dialysis rather than dialysis. So the non-dialysis group is the one that does not get dialysis for various reasons, including not being able to afford dialysis, compared to the dialysis group, which is able to receive. But even when you define the dialysis group, like you had said, our idea of dialysis may not be similar to the proper international definition of dialysis.
Yeah. So I'm just scrolling through. Yeah. So if you, moving on to your sort of third chapter and the exclusion criteria, and you were using mobile phones for the interviews, would that be creating a bias? I mean, does everybody have access to a mobile phone, or are there going to be some people who don't even have a friend, or the signal's so poor that they can't really use one?
Well, we thought that this would actually be a problem for our patients, but many people actually do have a mobile phone. And even if they don't have, because many people have, most patients actually have access to a mobile phone. So if you look at the way in which, like, finally, how many patients were excluded because they didn't have a mobile phone, the number is actually quite small. I think it was about 4 or less than 10 patients because they did not have access. So because when we got to that as our exclusion in the patient flow, then we thought that maybe it's not going to be such a big problem in terms of bias.
Sure. Okay, that's good. So looking at figure 11, where you've got the Kaplan-Meier curve showing survival of people on hemodialysis. Again, you really just need a description of how many people actually stayed on hemodialysis. So, of the people who started, how many were still on dialysis at the end of a year? Something. So that really just comes back to my first comment that you need a paragraph somewhere.
Okay.
Because there's two ways of interpreting that curve. That either the quality of hemodialysis is so bad that everybody dies, or that people just stop coming. And it sounds mostly it's people stopping coming. Some of it is going to be quality because you're only doing it twice a week and with central lines. So are the central lines tunneled, or are they non-tunneled lines?
Most of them are non-tunneled lines. Most of them are temporary lines.
Yeah. So again, that needs to be stated because that's really not an international standard, as I'm sure you're aware. So figure 12, which you've labeled as conservative management and hemodialysis, I mean, that really should just be non-dialysis and dialysis, because this isn't, it's choice restricted conservative care. Then looking at your section 4.4.2, quality of life scores, I'm fairly familiar with quality of life scores. I always get a bit confused about which go up and which go down. And certainly for, and it's not always intuitive, for, non-experts reading it, I think you should just have a statement somewhere that needs to state that a higher score is better or worse for each thing that you're measuring. And doing a timed, you just need to make a point somewhere that by the time you're doing a longitudinal study, which is always difficult and difficult to interpret, that by the time you're doing it at the end, it's your survivors, isn't it?
Yeah. Yes, that's true.
So there is a bias in the later ones that
Yes.
that
Yes.
they've survived, and that's just worth sort of a statement. There's nothing you can do about it, obviously. I mean, it's great that they have survived. And that really brings me on to your big table 12, with all the quality of life change in individual qualities of life. I really had two comments about that table, that you should have a description that how many patients there are at each period. You just need n equals.
Yeah.
They're going to have died. I mean, did you find that everybody did their repeat quality of life, measurements, or did some just say, I've done enough forms, I don't want to do it again?
We found that close to 90% were happy to do their repeat forms again. But of course, there was that 1%, which was very small, which did not do their tests again.
Yeah, so you don't have, which is fantastic, and that's worth saying, because in most studies, people just get bored with doing it, and certainly in my own study, the drop off is down to about 70% by the end. End of the study.
Yeah, so that is why we also recommend that it's more of a research tool and not an everyday
absolutely. Tool. And just as a general comment, you've got an awful lot of, I'm not a statistician, so I'm not going to say much about statistics, but I do know that if you've got multiple p-values, you do need to do a correction. Because there are problems when you've got too many p-values. So moving on to the qualitative interviews, how did you come up with the questions?
Yeah, so we first of all did a very extensive literature review. And then we actually published in our protocol paper the interview guide that we used. And we tried to, because we were really focusing on quality of life, we tried to look to make sure that all the questions are covering all the five aspects of quality of life. So that was mainly the framework. And the way in which we applied the questionnaire is that it was really a guide for the patient. So we had questions about the four different, we had questions about daily life, questions about, social health, physical health, all those different things. And it was meant to be a guide so that we're able to get answers in that specific perspective. But then when we were analyzing the information, we were forming codes and then eventually themes so that we are able to understand the data. And after that, to be able to report it, we try to see if it fits in with the framework. So it means that some of the questions, some of the themes may not actually align with the framework, but then some of them will actually be to fit into the two different or two or more aspects of the quality of life.
Did you have a patient involvement in helping guide you with the question formulation?
So we tested, once we got our interview guide forms, we tested it with the patients to kind of see if it made sense to the patients or not, and to kind of see initially what kind of answers we will get. And once we were satisfied with our frame, then we were able to apply it for the study.
Okay. Do you think it would have helped? Because it's, again, certainly in the UK and I think in the US now, it's almost compulsory to have patients as part of your research group. Do you think that would have made a difference to your study?
I think we involved patients right from the start. So for both the kidney disease quality of life tool, we involved them for the cognitive interviews, and also for the qualitative bit, we involved them for the cognitive interviews. So I don't see how extra involvement would have made any difference to the results that we finally got.
So, I mean, I found the interviews really the most interesting part, and particularly the role of religion, which was really very different.
Yeah.
Do you think this is unique to Uganda and Ugandan culture?
So looking at all the literature, like a lot of papers have been published regarding religion or spirituality, because spirituality and religion are not exactly the same thing, but regarding spirituality and healthcare outcomes. And they've been published from different parts of the world, and most of them actually show that there is survival benefits for some studies when you look at religion and spirituality. Of course, there's some places where it's a bit conflicting, but we think in Uganda it might have been unique. For example, we have religious workers who come to the post, we have churches which will send people to the hospital to come and do some charity work. So we thought maybe that's what influences and makes religion actually a improve survival for patients, because they're able to access their spiritual care workers, maybe even much more they're able to access the healthcare workers. So we thought that in our setting, it might be a little bit more unique because they're always in the hospitals, always around the hospitals, and that actually enforces the religion aspect for patients.
Okay, so I'm now moving on to your discussion, and you're comparing, so chapters 7, and you're discussing different quality of life studies and scores. I just wondered what you whether you thought this was a valid thing to do, or what are the challenges of discussing, you know, the actual scores from, and you again, you did that in your talk, discussing scores between different populations.
So we thought that the tool, because it has been applied to different populations, then it tells you what the quality of life is in that population. And then because it's the same tool which is applied in different populations, then you can be able to compare because you're using the same tool. And also it helps you. So the tool will help you, first of all, as a baseline, so that you can see, okay, we did this intervention, how are things changing? But it will also help you to compare to others to see if they are much better than us, what should we do to make life better for others? So that also kind of encourages you to do better because you see where you lie in the grand scheme of things.
Yeah, but do you think that, and this is more of a sort of philosophical question, if I asked you about, or somebody, you know, in Uganda, about your health, is it good, you know, etc., do you think the response is going to be the same as, say, somebody from Saudi Arabia or somebody from UK or something? I mean, what's the cultural influences on quality of life?
So I think that if you ask someone what their quality of life, it may not be the same. Well, because the tool looks at so the idea is that you have your baseline expectations, and then you have you have your expectations, and then you have your reality. So because the reality is different, the expectations are also going to be different. So you will not say that it's exactly the same between the two different groups, simply based on the reality, because the realities are different. But if you apply the tool, which has been validated in the setting that you apply it, the theory is that you should be able to get something which is close to similar between the two different groups. And that's why we thought it's really important that we validate the tool for our setting. So that we see in our setting, what quality of life do we have? And the difference is that if you're in a high income setting, you have high expectations. And therefore, if your quality of life is high and expectations are high, you will have that degree of high quality of life. But the gap will still be close to the same as here, because we may have less resources, but our expectations are just as low. So because of that, you'll be able to compare if the tool is validated in the setting.
Yeah, but it's also, I mean, the DOPS data, for example, shows that one of the major influences on quality of life was actually country.
Yes.
And is that, you know, when I did the analysis of hemo and PD, which you may or may not have read in AJKD, the major influence on all the quality of life measures was actually not dialysis modality, it was country.
Yes. Yes.
So there are a lot of psychosocial things outside dialysis, which is affecting your quality of life.
Yes.
So, I mean, are there any studies looking at quality of life in other aspects of, you know, in other groups in Uganda or African countries? You know, it can be healthy people, and comparing them to a higher income country.
Yes. So so maybe that is something that we can add as well to compare quality of life within Uganda. Maybe it may not be within kidney disease, because we don't have in kidney disease, but maybe to other diseases within Uganda. The
Yeah. problem
is that it will be different too. So then we'll have to factor that as a limitation to that comparison. But that's something exploring.
Yeah, but you may find, and again, I'm just speculating, that people in Uganda are generally happier
Exactly.
than people in United States. And again, you can't just say United States, you'd have to say in Hispanics or non-Hispanics or, or whatever.
Yeah, that's very true. That's very true.
So sometimes it is a bit difficult to compare. It's a bit like comparing apples and pears, because I think there's so many different things that influence quality of life or people's perceptions. I always remember a first-year medical student being asked to interview a patient on dialysis, one of my patients, and the medical student was and they were meant to be asking about health, and the medical student was shocked when the patient told him he was in good health.
That's very true.
Yeah.
That's very true.
So it's all about perceptions, which makes the whole area really interesting. But the fact that you find the same or slightly worse quality of life on dialysis compared to non-dialysis is really just, the cultural influences are the same for those two comparison groups, and it's really interesting. So I now come into your thing that one of the things that could improve quality of life is by regularly measuring it, as they do in the US. And I'd like to take issue with that. Do you know what happens to the US annual forms?
The recommendation is that it should be regularly measured. And US is just an example, but it doesn't have to be that frequent, especially with this tool. So that's why one of the other recommendations is that maybe we need to have a screening tool so that we can screen people probably on an annual basis. And then the ones who are found to have low quality of life can then be assessed properly with a more detailed tool. But to apply it very, very often is also to tire patients, and that does not improve their quality of life.
Yeah, I think that a lot of the American forms just sit in a database somewhere. So unless people actually pick up on the issues at your next clinic appointment, it's pointless. And it's often just best to ask the patient how they are. So how are you going to build in spiritual well-being and support into your patient groups? I mean, I like that as a recommendation, but how are you going to, is that feasible?
So I think it's feasible because we have a lot of religious sectors which come in to support patients. So the idea that it is important actually helps us to know that we should do something about it. And therefore, building it in maybe things like having maybe early morning devotion every time patients come for dialysis, maybe having someone pray with the patients, or trying to involve all the different religious communities so that patients feel like there is some spiritual aspect to their care.
And who pays for this, the spiritual support?
So most of it is done voluntarily by the religious groups, but this is why finding that it's important means that maybe someone has to pay for it so that it is implemented in a more systematic manner.
Yeah. Okay, so I'm now moving on to your last paragraph on page 100. I got a bit confused by this because, again, you were talking about longitudinal studies. And the changes that you found that you you had some improvement, but etc. And then you compared it all to some studies in Japan. And I think that this is, I mean, there's a big difference between the Japanese studies and Ugandan studies. I mean, what do you think, which makes that comparison difficult?
So first of all, the resources are different for the two. But I was trying to look up a study that longitudinally explores changes in quality of life, and it was difficult to come by. And this is one of the reasons why I ended up using this study in Japan, bearing in mind that the setting is different and the outcomes may therefore then be different.
Yeah, and presumably people stay on dialysis forever in Japan.
Yes.
Because they don't have transplants, and they've got very good dialysis care. So it's very different.
Yes.
I mean, what are the challenges, do you think, of doing a longitudinal quality of life study?
So to begin with, dropout rates might be high because of mortality or patients just not attending anymore.
Yeah.
But one of the things that would improve dropout rates is having good contacts. Our system, our healthcare system is not electronic. So also getting access to those longitudinal healthcare information is a problem for us. Most of the time, patients' medical information is on a piece of paper, which can get stolen or get burnt in a fire or something like that. So access to that healthcare information is, to begin with, very difficult in our setting. But then also being able to access the patients because they change, they move. And I think the follow-up is a big problem. And we try to counter that by having multiple phone contacts in our setting, not just the patients, but someone else's as well. And then applying the same tool, because if you do that, then you're able to keep and maintain the information for yourself without having to rely on the patient keeping the information for you.
Yeah, and that's why there's such a paucity of longitudinal data. But I think if you're wanting a good, I mean, it's not just because it's, I was the first author on it. It's because it's from DOPS, and then they did the work, not me.
Yeah.
And we did attempt to look at 12-month changes, so it's over the same time period.
Yes.
And several thousand patients. And actually, they're very difficult studies to do because of all the reasons you've said.
Yes.
And I think the main finding was that most people stayed the same. Few got worse, few got better. So if you want a comparison study, that's a better study for you because A, it's more recent.
Yeah.
And secondly, it's big groups and it's international.
Yes.
And it's over a 12-month period, so it's over exactly the same time period.
Yes.
As your study, but overall, I think the thesis is excellent. So, what are you going to, if Godfrey turned up now? What are you going to tell him? Now that you've done the study.
Well, I'm going to tell him that he's the exception, because most of his cohorts actually didn't make it, how far he has gone. So I'm going to tell him that he's the exception. But also, if a type of patient like Godfrey turns up who has not started dialysis and he has end-stage kidney disease, I'll be able to tell him that there are things you need to have in place to be able to survive on this therapy. One of the things is that you should have good social support. So make sure you harness your support systems. And the other thing is that you should have good dialysis. So you should ensure that you have at least 3 times a week dialysis or have AV fistula put in place. Because if you don't do these things, your survival is going to be very short.
Yeah. And would you recommend that they actually, so like the family who sold up everything,
Yes.
what would you say to them now?
So for them, I think the most important thing is give them the information upfront. Make sure they know that this is a long-term problem. So if you choose to sell everything, then you're going to lose everything and still need more to be able to continue dialysis. So giving them that information upfront and making sure that they fully understand it and they make a decision with that information in mind, I think is the most important thing.
And what are you going to tell? I mean, hopefully you're also going to use this work for advocacy.
Yes.
So what are you going to tell the powers that be, hoping that you're going to get some changes?
So I'm going to tell them that our dialysis saves lives, but it is not doing a very good job, especially in comparison to other places. So we need to invest more in our dialysis. We need to develop the support services. Connecting patients to dialysis and disconnecting them is not the end. We have to have people to give social support to patients. We have to be able to ensure that we do 3 times a week dialysis for patients. We have to be able to make sure that our patients are supported, not just with dialysis, but with all the support services that are required to be able to make dialysis safe or to be able to make dialysis the survival modality that it is in other settings.
And given my professional interests, which I'm sure you know about, what about you haven't mentioned peritoneal dialysis once. And,
so yes.
and that would get round the geography issues, wouldn't it?
Yeah, it would. So that is also another option for patients who are especially far away. Yes.
Yeah. Okay. So I'm going to conclude at that point. And thank you very much for all your answers.
Thank you. Thank you very much for examining my.
Thank you, Professor Brown, for this interactive session with the candidate. And next we'll move to an interaction or questions from the examination panel. We'll start with Professor Julia Downey. Please, you can unmute and ask your questions. For those of you who have been in Uganda for a while, probably you know Professor Julia Downing. She spent a lot of time here. She's a professor in clinical palliative care, a researcher and educationalist. She has vast experience in healthcare provision in Uganda. I hope you've read the Handbook of Palliative Care in Uganda. It's one of the others. So Professor Downing, you're welcome. You have 5 to 10 minutes to interact with the candidate.
Thank you very much. Can you hear me okay, Peace?
Yeah, yes, we can.
Great, thank you. It's great to be with you today, and thank you for your presentation just now. And I'd like to thank Professor Edwina as well for her questions, which some of which led on to some of my questions or thoughts to you. And I think linking into that last question about advocacy, and you talked about wanting the government to fund for three sessions a week. So I just wondered, from this study, how many of those on dialysis had 2 sessions a week and how many had 3 sessions a week, and whether there's any data from this study that can support that advocacy. So, I mean, obviously the numbers will be smaller, but I'm just thinking about, the quality of life, etc., and mortality, whether there was a difference between those on 2 sessions and those on 3 sessions.
So we didn't put that into, and that's actually good guidance. So we shall put a table talking about the numbers of patients who are receiving 2 times a week, 3 times a week, dialysis, but the system in the hospital is that patients get 2 times a week dialysis paid. They have a subsidized fee for 2 times a week dialysis, and then they get a pool fee for the 3rd session of dialysis if they have to have one. So for that reason, over 90% of the patients will have 2 times a week dialysis. And then we also know that there's a percentage who will not attend. So you're able to get 2 times a week dialysis, but you don't attend because of one reason or another. So there's also a big percentage of patients who are not as regular as they should. So that would be good information, but maybe also the anecdotal evidence we can add as well to make the picture clearer for the reader.
Yeah, because it just thinking about finances and the impact of the finances that the government are giving. If we can clearly show that 3 sessions a week will make that big difference, then
yes.
That can be then fed back into the productivity of the patients, etc., etc.
Yes.
And another thing I was quite interested in is that you said that some patients switched between having the dialysis and not having the dialysis, and vice versa. And I just wondered how many did that, and whether there's any implications of that on the outcome.
So usually the switch is from doing dialysis to not doing dialysis. That's what we found. Because when you start off, you don't understand the implications of doing dialysis. The implications of doing dialysis that's ongoing, and you're going to be paying this for long. So most of the time, patients will start off, they'll have also social support, people come in, pay. But 2, 3, 4 months down the road, the people kind of cut down, no one is supporting you, the donations are cut down. So most of the time, the switch is from doing dialysis to not doing dialysis. So maybe that's another paragraph that we can add in to make it clearer what percentage of patients switched from doing to not doing dialysis.
Yeah, I mean, I think it's just a bit like what Professor Adrina was saying. It's helpful for people who don't know the Ugandan context so well to have a bit more of that information when they're then interpreting the results. Another thing, and I'd like to congratulate you because you continue doing this study throughout the COVID pandemic. But I'm just wondering whether you thought the pandemic might have had implications on how you conduct the interviews, but also do you think the pandemic itself might have implications on quality of life and therefore the results of the study? So do you think it would be the same if you did it again now outside of the pandemic? Or you have no idea?
I think so. The main difference, at least in my qualitative studies, because I did all those myself, was that I had to travel to get to the patient's home. But then we gave all of our patients travel letters, so they were able to travel to their dialysis units. For the ones who are on dialysis, it's the ones who are not on dialysis where it's not really clear if they could have dropped out more because they're not able to access healthcare services. But in most cases, once the patient had a medical letter or a medical paper, they are able to access care for that particular reason. So I cannot really estimate, but I would think that the pandemic probably had a minor impact on the outcome of the study.
Because it's interesting, because some data has shown that generally quality of life decreased during the pandemic, but for some people actually their quality of life increased. So it's just so I was just interested in that. And obviously, I've got a palliative care background. So what do you think the implications of this are for perhaps the provision of palliative care for people with end-stage kidney disease in Uganda?
So I think that palliative care now plays a major role because the patients who are not on dialysis, so the equivalent is perhaps maybe they're getting some form of palliative care, although during the study period, it's very few patients who are actually linked into the palliative care service. But the implication is that incorporating more and early palliative care services to these patients may actually improve their quality of life even more.
Yeah, so that would be an interesting kind of next step to the study, is to look more at, early integration versus non-integration or whatever. And also, I was interested because in your thesis you obviously included your published protocol that you got that was published, and in that you were also talking about using the APCA palliative outcome scale and the POSES renal. But then obviously you didn't use it in the study. So I just wondered your rationale for that. Your thoughts on that, really.
So when we started to apply the kidney disease quality of life short form, it's a very long tool. And because it's a very long tool, it took up so much of the patient's time that they didn't want to add anything extra on top of that. And then also the APCA POS has a section where they look at the symptom burden. It's almost the same amount of the same that they look at with the kidney disease short form. So we thought maybe, let's go with this because it's the most important, and subsequent studies we shall add the APCA POS.
Yeah, I thought it might be the burden of questionnaires and things, because that was a key issue, isn't it, in this client group. So okay, I think some of my other questions have already been covered by Professor Irina. So I'll hand back to the team there in the room.
Thank you very much for reading my book.
Thank you.
Thank you, Professor Downing. Thank you, please, for sustaining the response. So we'll move to the internal examiners. 5 to 10 minutes. We'll start with Professor Bruce Chirenga, who's a professor in medicine with a keen interest in pulmonology. He's a clinical research scientist and director of Makerere Lung Institute, and he's also the college principal. So, Bruce, over to you.
Thank you. Peace, congratulations for reaching this stage. Your PhD. Most of my questions were covered during the time of opponents. Yeah. I just want us to discuss one area, and you can guess it. It is the analysis area. So this study is very important. We don't hope that these people bad kidneys, and you assess their quality of life. And you found many of them after they had poor quality of life, which I think you knew before you started the study.
Yes.
As a nephrologist, even if it's very far.
Yes.
I know these kidney guys are not doing well.
Yes.
So therefore, the important thing in this study is, why do they have this very bad quality of life?
Yes.
Which I think we also knew before this study.
Yes. I had an idea.
You had an idea.
Yes.
Because other people have said they are getting dialysis twice a week, sometimes they don't get it. It comes very late when they are really too sick. So therefore, it takes me to the analysis, and I think it is the opponent who talked about it. So by you finding that dialysis is not help,
Yes.
you needed to look deeper if this is really true. Because the recommendation will come here, tell the government, please do not give your twice a week dialysis. These guys, it's not helping. Please give what should be given.
Okay.
And that will bring us to discussions. How do you ratio this dialysis? You'd rather give some people 2, which is useless, to 10, or give 5, something good, and they survive. And these are all your things as so it brings me to analysis. So when you did this analysis to find the drivers of this poor quality of life, you looked at dialysis as a stratification factor.
Yeah.
not as a predictive factor. Now, when, okay, maybe let me ask you a question. What do you think is a problem with that? Because we are here to ask questions. What do you think is a problem with that?
So the problem with that is that the problems probably have already occurred to get patients to the stratification area. So, like, I think the drivers probably have already occurred. So things like patient want to be on dialysis, maybe already because they first of all maybe not even make it to the hospital in the first place, the tertiary center in the first place, because maybe they have no funds, or because maybe someone was not able to define to find out that they had kidney failure to begin with, or they died in a community.
Exactly. So
Yes.
there are many other things affecting this.
Yes. Yes.
So in that case, in the analysis,
Yes.
we need to adjust for those things
Yes.
before we can condemn to say this thing is not one.
Yes.
So in a way, Chair, I think that's where this is. That if you are convinced beyond doubt, then the recommendation, I also had a recommendation based on that to come out very clearly to say that probably we should give people the standard dialysis
Yes.
than to just give them
Yes.
this public
Yes.
something to make people think we are giving people dialysis when they are not giving.
Exactly.
So I think you go back and make sure that that is handed out
Very strong.
very strongly, and I thought it was a very good finding because what we know probably that dialysis will make you better.
Yes, it's supposed to.
And we'll make the second last. And this also has been brought up, just to emphasize it. So these guys, most of them died.
Yes.
Yes?
Yes.
How many? 80% by 1 year.
Yeah, 74%.
74%. And you are doing longitudinal assessment of quality of life.
Yes.
Did you, that's why I said I'm going to concentrate on analysis.
Yes.
Did you censor this? Because these guys who are surviving up to what?
12 months.
12 months, they have something about them.
Yes.
So if you put them together, these guys who died in month 1,
Yes.
they don't see exactly. That is also the improvement of the analysis which you can do to really conclude that the analysis should be given in useful form.
Okay.
Chair, last, this one I may not give an answer. Maybe you are going to educate me. This validation, like a objective.
Yes.
Was it an objective or an activity in those related to this?
So it was study preparation, which is under study preparation. So we had to get a tool which works in this setting. So because it was a study preparation plan, that's why we called it the methodological objective, and it's not part of the main objectives. The main objectives are the top 3. That's why we made it objective 4. Methodological objective.
Okay. The first time here I'm seeing this. So you did very many things to prepare for this study. Why are they not the objective?
Well, because this one was a detailed analysis of a tool. So if it does not make sense, then you can just remove it. But we actually did a lot of work as part of it. So we thought that it makes sense to include it as well. But it's not the most important thing. The most important thing are the top 3 objectives.
So, Chair, I really want to thank you. I learned a lot about quality of life. Minded myself of my nephrology of 20 years ago. Submit.
Thank you. Thank you very much for reading.
Yeah, allow me to continue online.
Accepted. Thank you, Professor Chilenga. That interruption. Our second examiner is Professor Irene Diabinaro, who's a professor of medicine, a keen interest in infectious disease and immunology, and she's our director for postgraduate training, Department of Medicine. Irene, welcome.
Thank you, Chair. I'm last on the line, please. So, Thank you for doing very well, and thank you for a very good presentation and defense presentation. And the story of Godfrey really brought it home. I'll just ask some of the questions that maybe for emphasis, some of them. You use the pragmatic approach in selecting your arm. So probably this has a limitation of some selection bias. For example, it could be economically driven because you had more males. We know males have poor health-seeking behavior.
Yes.
So it's surprising that there are many males in your study.
Yes.
So is it because they had the money? Are they the most afraid to die and they thought, I need the dialysis? I wanted some more just explanation on this social determinant.
So we thought that because the tertiary facility, yes, that means that you have to be able to afford care, to be able to access the care. So we thought that probably more males, because they probably have more access to financial services compared to females. That was our main rationale. That's why we thought probably that's why we have more males than females.
So do you think that the fact that the females ended up now not getting dialysis, but they had better quality of care, do you think it was a gender driven result? Because as females, we are more optimistic, we are happier, we are more religious, we are more that.
Yes.
So could that confound your results and as well?
Yeah, it's possible. It's possible to think about it in that angle. That it could add a little bit of compounding. That's true.
Okay, so then it also drives me to the conclusion about gender and religion, because these are your main conclusions.
Yes.
So are these two factors having an interaction effect? And maybe they could be interacting with maybe underlying comorbidity or severity of disease. And so we're not able to see the actual conclusion on the effect of having dialysis. And these are just interaction factors. So how would you manage interaction factors?
Well, so for example, a bigger sample size might be helpful, but also maybe better patient selection. Say, for example, to have a bigger sample size of dialysis patients alone and look at that group, and maybe have a bigger sample size of patient selection alone and look at that group and see if maybe that comes in as a bias in that particular area.
So what non-pragmatic way would you have designed your study?
I'm not sure. I think that maybe to have all the patients come in regardless of and not select between one management group over another management. Yes, maybe.
Or even at analysis.
Or even like select along other lines rather than just management type. Right. Yeah.
Then I also have were they the same interviewers at every time point?
Yes.
So the same interviewers and the same.
So the qualitative interviews were all done by myself for all the patients. But like maybe 3 or 4 were done by somebody else, so that we can they're all done by myself, but the analysis was done by myself and somebody else, so that we can agree on the codes before we got to the eventual theories. But all the qualitative interviews were done by myself, and all the quantitative were done by the same research assistant.
Thank you very much, Chair. I think I will stop at that.
Thank you. So, thank you, Biz. More or less, the examination is done. Can take some water. So we'll have a few questions from the public audience. I know we have quite a number of people online and those who are present physically. So we'll ask a few questions, make it short, make it fast. You raise your hand up and we'll unmute you. So I will start with the people who are present physically. I hope I'm part of the public. Eh?
Yeah, you're not an examiner.
I'm not here trying and ask.
Yeah.
If you were, well, okay, you introduce yourself, then you ask your question. I'm Mark Kadunkasa, a physician. If you were to redo this study again, what would you change?
So I would want to add other parameters that we know for sure affect quality of life. Yeah? So I'd want to add things like clinical parameters, like the patient's hemoglobin level, patient's calcium levels, like clinical parameters. I'd like to add that because other studies have shown that they actually help. And then, if I could, I would like to add an implementation part to the study. So make sure that the patients who are getting non-dialysis care are actually getting the real renal supportive care that we give to the patients who are getting non-dialysis care. So renal supportive care would be things like giving them access to, connecting them to the palliative care team so that they have good symptom control, they have access to the people to give them information, spiritual support, and then actually see if that is the reason why their quality of life may be a little bit better. I think that's what I would do.
Thank you. So for the people who are enrolling for PhD, I've had the possible studies. Yes. Introduce yourself, make it brief. One.
They are brief ones. One, more male versus is that a one trend or was it just an aspect? And then two, young people, average age 40, 46, 46, most likely 43 at the start.
Yeah.
So, what are the risk factors
For young people?
Yes, for young.
So in this case, your first question about gender, we thought that the reason why is because of accessibility and affordability. For males, maybe they're more able to afford tertiary care compared to females. It's the worldwide trend. So like some of the studies I quoted, male gender has decreased risk for mortality. And we know that females have a better health-seeking behavior worldwide compared to males. So the results probably in this case, because of affordability, there might be other things, but that's probably something worth exploring. And then in terms of why young people, I think the reason is that in our setting, for example, we know that kidney disease is not easily recognized, and many people will get it in childhood because maybe they have like nephrotic syndrome or they have like malaria. Sometimes not even malaria, but infectious diseases will be a contributor. And then because no one thinks to, because with kidney disease, you have to do the blood test and actually confirm that your kidney is not working. So if you are in a health facility where no one thinks to do the blood test, then you will not be identified early. And if you're not identified early, they will show up later. So the kind of health system we have is probably one of the reasons why. And also the sensitization or the community perspective that you have to be old to be able to get kidney disease. That's not true.
Thank you. We move online. No question here. Emmanuel Mwesiga, unmute and pose your question.
Thank you, Piers. Emmanuel Mwesiga, I'm a psychiatrist. I'm interested in quality of life. My question is about now that did you take steps to get consent from Godfrey now that you have de-identified him?
Yes, I did. I did. I asked him if I could use his story and be allowed as long as I change his name. So Godfrey is not his actual name.
Okay, thank you.
Thank you. Kutegeka. Kutegeka, are you there? Your hand is raised. Unmute and ask your question.
Yeah, I'm there. Am I? Am I being heard? Dr. Peace, she has made a presentation. My question is, as far as I know, dialysis in Uganda not a wide spread service to the whole country. Are there measures being taken that this service is extended to other regions? Because as far as I know, most people get dialysis when it's too late, like the presenter presented. That's my question. Hello?
Maybe you could ask your question again.
Okay, my question is, are there measures being taken to extend the dialysis service to other parts of the country, because it's not wide spread in Uganda, as far as I know?
Yes, so the answer is yes. So I showed you the picture of where that's available in the country. So the 2 stars I showed you is new centers which have recently been set up in the last 5 years, and that's in Valley and in Lira. So the government, with the help of the Uganda Kidney Foundation, is actually doing a lot to make sure that we expand dialysis services. I'm hoping in the near future that we shall have services available. I think the next center will be in Hoima, and then there are also private services coming up in Kabale and maybe in Fort Portal.
Thank you.
Thank you. So we have a question in the chat. I think the first one is from Nicholas Igeni. What informed the use of 50 as a cutoff for the score of quality? If patients who scored over 50 survive long?
So what informed 50 as a cutoff is that when the tool was formulated, they designed 50 to be the cutoff. So if you have above 50, that's a good quality of life. If you have 50 and below, that's a poor quality of life. So that's the standard for how the tool is interpreted.
Okay, thank you. We'll take 2 more. One is from Dika. But how did you control for positionality and reflectivity effects, the outcome, since you carried out the interviews yourself with the patient?
So to begin with, I tried to have other people analyze the information so that they're able, so that we formulate, at least agree on the coding tree. And then after agreeing on the coding tree, then I went ahead to analyze the study findings. So that's, as I am definitely biased because I deal with these patients, but having other non-nephrologist people review and have and inputs actually helped to reduce that.
So the last one has no name. That is saying that there's a lot of religious influence on patients with chronic disease, where incidents not clear. It's not accurate. It's asking about religion as a deterrent for seeking care and dialysis. No, I will leave that one. It's not a clear question. But it's asking about probably the impact of religion and how it's people seek medical care.
Yeah, we had some of the patients talking about, like, that was part of in the qualitative interviews, that the problems navigating the healthcare system. So some of the patients actually say, when I got body swelling, people would say that I am bewitched, and so they would go to traditional doctors or go to churches and eventually end up in the hospital. So that's actually one of the things which came up, showing why it takes patients so long to eventually get to the hospital. So we acknowledge that's actually a problem and a movement.
Okay, so that brings us to the end for the public. So thank you, members who are online, the examination panel, and those who are present physically for staying with us. We are now going to take a quick break to determine outcome. Then we'll be back briefly. For the examination panel members who are online, you're going to be moved to the what do they call it? Breakouts, section for the verdict. Then we'll should be maybe 5 to 10 minutes. Then we'll be back. In the meantime, you can have a cup of tea.
I'm not sure. Can anyone hear me? Because I've been kicked out of the other room. I was in
the wrong room.
I was in the breakout and then I got pushed out.
Just a moment. Let me see. Just a moment.
Thanks.
Looks like you have taken us back to the main session. Can you take us back to the breakout session?
I just want
The breakout session closed, I think.
give you the verdict. So welcome. We are back for the last part of the defense. And I see the examination panel is all back. So I will hand you over to Professor Brown, who will give you the verdict. Then I'll fill in the details. Thank you. Professor Brown, you are welcome.
Okay, thank you. And thank you, Peace, for a fantastic presentation, fantastic piece of work, which I look forward to being used in terms of advocacy within Uganda to expand access to dialysis for people in Uganda. But can I suggest peritoneal as well as hemodialysis? Because, you know, that gets around some of the geographic issues. And also, you know, having to turn up the emotional and economic issues of turning up for hemodialysis. But in terms of your thesis, we all thought it was excellent. We gave it a good score, and yes, you've passed, and with very minor corrections. So many congratulations. So the minor corrections mostly are around describing the hemodialysis group in slightly more detail in terms of, you know, how often, how, you know, access, you know, when did people stop, etc. And also about the use of the term conservative care, saying this is choice restricted conservative care, and using the term non-dialysis in sort of figures. So those were the main differences. But I will let your local Ugandan colleagues tell you about those in more detail and how to prepare the corrections and what the timeline is. So many congratulations.
Thank you. Thank you very much.
Congratulations, Peace. It was really well done.
Thank you. Thank you very much.
Oh, now you can take a breather. Congratulations. So you pass with minor corrections, and we hope that you receive the areas you're supposed to work on and improve.
Yeah.
And within a month, you should be able to submit to Professor Ndia, who will ratify that the corrections have been made.
Yeah.
Then we can hand you over for graduation. So congratulations.
Thank you very much.
So that ends the PhD defense. But before we sign out, we'll request you maybe to say a few remarks and take a picture. Sometimes you cut a cake, I don't see it. So over to you. You have a few minutes.
Okay. So I've thought about this moment for a very long time. This is the very first day I started my PhD because I attended, I think, Dr. Kaima's defense, and after talking about all of his hassles and all those things, they gave me this moment. So I always thought about this moment for a very long time. And I actually used it as a tool to scare everyone, all my friends. I told them, if you do not help me, I will not mention your name. So I am so very excited to actually reach there. It's really a dream come true. I remember I sat in this very room when we started this PhD journey. So the Pride Consortium is who sponsored this journey. And I remember very clearly Professor Sewakam was saying that he did not like giving clinician scholarships for PhDs because they don't finish. And I thought that, why would he say that? Like, this is me, I will finish in 3 years tops. And this is 8 years down the road, and I'm finally having this moment. So it was a big driver for me to prove to him that, you know, clinicians can. And indeed, it's a hassle for clinicians because patients are calling you all the time. It's just so hard for clinicians to actually sit down and put patients on the side so that you can write work. So to all the clinicians out there, you can do it and you need to do it because it actually helps and makes your work better. So I hope that all the clinicians will be inspired to do it. But I cannot not thank everyone in this room. You are all so supportive. I can't thank you enough. I'd like to thank all my teachers, all my supervisors. I was really excited to see Professor Katarina here. My supervisors have been the best. They've been with me throughout, and they've written blogs about me and how I cannot spell words. But you can overcome anything, and I think this will hopefully be a moment for that. So thank you all so much. I'm so grateful. And I thank you for this moment. And I thank everyone who read my book. It is a big book. I thank everyone who took the time to read it. I know Professor Julia probably also had everyone had a hard time reading. So I just thank you all so much. Thank you, thank you, thank you. Thank you very much. Dr. Moira is also online. Thank you so much, Dr. Moira. I don't know if Mila is around. Thank you so much. I don't want to mention names. I promise myself I'll not mention names. So thank you all so much. Thank you, thank you. Yeah.
So
What's up?
thank you. That concludes the defense. I think we can have a photo of memories, and for the people online, please stay online. You can put on your videos so that we can see you. You can.
The view. That's fine.
Usually you take a picture with your examiners, supervisors, or the examination panel, then the rest.
I've been kicked out, so I need to do this quickly.
Then the rest. Thank you.
Thank you. Thank you very much.
So, congratulations.
Thank you.
So, have a good day.
Thank you.
Thank you. Thanks, everyone. Bye.
Bye.
Yeah.